I'm Ann Partridge, and I'm here now as a new Chief Scientific Advisor for Susan G. Komen, and I have the distinct privilege today of introducing one of the marquee awards from the Susan G. Komen Foundation, the Brinker Award for Scientific Distinction in Clinical Research. These awards have been awarded over the last 30 years from Susan G. Komen to some of the premier scientists and doctors in our international community. And today, I am thrilled to announce the winner, Dr. Norman Wolmark, who will be presenting. But first, let me say a few words about Dr. Wolmark, who is no stranger to this audience, of course. He's being recognized for his outstanding contributions to the advancement of clinical care for breast cancer patients. As an expert in surgical oncology and trial design, Dr. Wolmark's work has radically changed the clinical landscape through studies that resulted in practice-changing surgical procedures, preventative interventions, and new therapeutic strategies and trial designs for breast cancer and colon cancer, by the way. His unremitting drive has resulted in decades of continuous achievements in patient care, paving the way for the era of preventative and precision medicine. I'm thrilled that Dr. Wolmark is here today, and he'll be presenting the contribution of NSABP clinical trials to the management of early breast cancer, passed as prologue. Thank you, Dr. Wolmark, and congratulations on this Brinker Award.
Well, thank you very much, Anne. I'm thankful and humbled to be this year's recipient of the Brinker Award for Clinical Science, particularly when viewed from the standpoint that I will be joining a cohort of awe-inspiring individuals who have had an indelible contribution on the scientific and clinical advancement in breast cancer, and I am truly humbled to be part of this group. So the contribution of the NSABP clinical trials to the management of early breast cancer, passed as prologue, a theme that was plagiarized, obviously, from the Tempest. And actually, in discussions with Ann Partridge, she inspired me to have a sub-theme from Halstead back to anecdotalism. We've gone full circle in so many ways. So, with that in mind, if I can figure out how to advance the slides. The green one? Green versus red. Okay, green indeed. Sadly, I have no financial disclosures, and perhaps somebody can illuminate me if they can find even a modicum of intellectual property in any of these slides. Get hold of me. Maybe we can work something out. Why do we have to put this trailer on every single slide? Can you explain that? For years. So, yeah, as you all know, the Brinker and the Komen is not just a passenger, not just a spectator. They are integrally involved, and we're integrally involved in this Brinker Award. I got a phone call and was asked some very poignant questions that created a sense of perturbation in me. I hadn't really thought of the questions and answering these questions. What have you accomplished to prevent and cure breast cancer in keeping with the core mission? Do we think about this on a regular basis? Are you leaving the field in a better state than when you inherited it? To recapitulate a quote from Ralph Waldo Emerson, of questionable provenance, but I digress. Have you changed and improved the standard of care of early breast cancer? If you read the Komen blog, which was very complimentary, it seems I have. And if that's the case, why did it take 30 years for the NSABP accomplishments to be recognized? Where were we for all that time? And keeping with our Shakespearean theme, a little soliloquy, an aside. Isn't he a little bit wilted to be receiving this award. Rhyming couplet, scene 2. What were the biggest challenges you had to overcome in your research? Of what contributions are you most proud? I could have answered that question in the same way so many people answer questions here. They grade the question. Good question. Then they don't answer it. I had to think about this. I had to give it some thought. And interestingly enough, these two questions have the same answer, and they're not related to scientific endeavor. What do you predict the next breakthrough in breast cancer will be? This is, going forward, looking into the future, which I thought was the domain of prophets, sages, seers, and other cognitive disorders, with an emphasis on precognition. And my batting average has not been statistically significant. Why do you even want to know my opinion? Flip a coin. And finally, the most dreaded admonition of all: if you exceed your allotted time, there will be dire consequences. I've already exceeded it. Look, that clock is moving. And there may be harm, although they didn't state this, to you and your progeny. That is daunting, ladies and gentlemen. So why did it take 30 years? It didn't take 30 years. It's just a cheap ploy to get controversy and drama into the audience, and perhaps to elicit a little bit of pathos for the speaker. In point of fact, as Anne pointed out, this is the 30th award. The first award was in 1992, and it went to none other than Bernard Fisher, the previous chairman of the NSABP. This photograph actually may be copyrighted. I think it's from Time magazine, so there may be intellectual property there. And then in 2010, Soon Paik, the director of our molecular pathology lab, won the Brinker Award as well. Soon was so instrumental in the development and validation of the Oncotype DX. We can claim Matt Ellis if we wanted to. He was head of our Translational Research Committee for NRG. We can claim Gabe Hortabaji, who for decades and decades was head of our Data Monitoring Committee. We see so many people who have been involved. Kent is sitting here in the front row. Thank you to all of you. So clearly, we are grateful to the Komen for their continued recognition of the contributions of the NSABP. So what were some of the NSABP accomplishments? Certainly, we will always be linked to the retreat from radical mastectomy. Always is, of course, a conditional terminology. We'll become an asterisk, and then we'll disappear completely, and that's the end of always. Postoperative adjuvant chemotherapy, the first trial, 1975, was reported. Tamoxifen in early breast cancer. B09 in 1981, one of the first reports of the value of tamoxifen. I think we sent the samples, and Kent, you remind me, to Bill McGuire to build up that tissue bank. B14 and B20 supplemented the indication for tamoxifen, led to the development of the Oncotype. First trials in neoadjuvant therapy, 1988. B18, pre-op AC versus post-op AC. And it was the first trial to show the importance of pathologic complete response as a surrogate of outcome and efficacy. Moving along to B41, we were able to increase the PCR from 13 to 65 to 70% for HER2-targeted therapy. The development of the Oncotype DX using B14 and B20. And in this meeting, the data were first reported in December of 2003. We are 19 years. Trastuzumab in early breast cancer. Who can forget George Sledge's educational session in Orlando at ASCO when the data from B31 and 9831 were presented and the HERA data were presented, and I turned around and looked at the audience and half the people were weeping. That was an incredible session. George, we congratulate you. practice-changing studies in DCIS, B17, radiotherapy versus none, 24, the addition of tamoxifen, 35, tamoxifen versus anastrozole, and B41, targeting HER2 with trastuzumab, which failed to meet its pre-specified endpoints, and our 2 breast cancer prevention trials, P1 and P2, which randomized 13,388 and 20,000 respectively, and provided expanded indications for tamoxifen and raloxifene. And I know Leslie Ford is in the audience. Thank you for all that you have done to support these trials, and for the people at the NCI who state that cooperative groups cannot do prevention trials. They are absolutely wrong. This was an absolute tour de force that changed the landscape and provided proof of principle. So we can't talk about all of these, clearly. Let's have some discussion on the retreat from radical mastectomy, postoperative adjuvant chemotherapy, and the Oncotype DX as developed from B14 and B20. So what is the NSABP? The NSABP was a creation of the National Cancer Institute, and we have been funded ever since. We were even named by the NCI. Do you think we would take this name for ourselves, this non-euphonious tongue twister that nobody can possibly remember? It was imposed on us by the NCI. Bernie Fisher became the chairman in 1967 when the group was still at Roswell Park in Buffalo. And then he moved it to Pittsburgh in 1970, and he remained the chairman until the calamitous events of 1994, when I took over as the chair of the NSABP. We enrolled our first patient in April of 1958, which makes us around 62 years old, approaching 63. And in 2014, as a result of the IOM recommendations, we merged for federal funding with RTOG and GOG. The N in NRG is NSABP. And we have randomized 120,000 patients into our treatment trials and have 100,000 annotated tissue specimens in our biorepository. So the NSABP was fortunate to have been part of the pivotal trials in the retreat from radical mastectomy. These were the trials that delivered us from the age of authoritarianism, the tyranny of an individual ascending to the professorial pulpit, armed with a retrospective case series, and able to dictate how breast cancer is treated for the better part of the century. These trials delivered us from that age of tyranny. Clearly, these represent 2 mutually exclusive hypotheses. These were not slides that were gleaned from some abandoned carousel or even lantern slides. Does anyone in this room know what a lantern slide is? This is topical. These patients were my patients on whom I operated in 1980. Speaking of the lack of equipoise, the patient on the right was randomized to NSABP protocol B06 and received a breast-preserving operations. I mean, clearly this represents an affront to the standard thinking of the time. Whenever one has the temerity to challenge the sanctity of the radical mastectomy, we pay homage to William Stewart Halstead, shown here in an unusual photograph given to me by my mentor, Mark Ravitch, 3 professorships removed from Halstead at Hopkins, showing some hitherto undisclosed humanitarian properties, such as his love of dogs and puppies. How did Halstead convince his colleagues, his coevals, his associates of the value of the radical mastectomy? He used the methodology available to him at the time, the anecdotal case series. This is from an 1895 Annals of Surgery. an abridged table where Halsted lists the then principal surgeons of the day. Halsted believed breast cancer was a local regional disease that spread along fascial planes. He did not think hematogenous dissemination was an important root in the biology of the disease, and he lists the local recurrences of the then principal surgeons. Billroth, 82%. Billroth, stick to the abdomen. 2 gastrectomies. And then, in an uncharacteristic display of humility, Halsted lists himself last on the table with an astounding 6% incidence of local regional recurrences, gleaned from 50 patients, 3 events. Ladies and gentlemen, these 50 patients dictated the treatment of breast cancer for the better part of a century. And to challenge it was anathema. Were there no minority opinions? Did somebody have the courage to speak out and say, no, this is not right? Of course they did. This is Rudolph Mattis of New Orleans, professor of surgery at Tulane, who, after one of Halsted's address to the American Surgical Association in 1898, stood up and said, no, breast cancer is disseminated hematogenously. It's not inattention to operative detail that causes treatment failure. A far more important question than that of local recurrence is that which relates to the actual number of cures obtained by present methods. Alas, the voice from Hopkins was far more convincing than that solitary whisper from Tulane. And Rudolph Mattis today has been purged from any of the history of breast cancer and is known for the resection of abdominal aortic aneurysms. But here we have articulately stated the 2 mutually exclusive hypotheses, the scalpel versus the hypodermic needle. 1898. And Bernie Fisher deserves an enormous amount of credit for resurrecting these 2 mutually exclusive hypotheses. And, of course, he paid an enormous price to do that. And, I mean, it is truly remarkable that he was able to do that and elicit the ire of the surgical community. I took this photograph of Bernie Fisher when I first joined him in 1973, at which point he glared at me and said, Norman, don't take my picture. He says, well, why not? He said, because one day you will show it and embarrass me. Perhaps one day I will, but it isn't going to be today. Of course, Bernie Fisher died in October of 2019. He was the first Brinker awardee. He died at the age of 101. When I came on the scene in 1973, just to give you an example of the enmity that existed at the time, there was an acrimonious exchange and battle between Cushman Hagenson, who was the best-known protagonist, who was espousing the sanctity of the radical mastectomy, and he labeled our studies by name a great leap backwards in the treatment of carcinoma of the breast, to which Bernie replied diminutively, this was in JAMA, and he called us out. Said, Bernie Fisher, he called out poor Sir Hedley Atkins. What did Sir Hedley Atkins ever do to annoy him? Basically, we were a pestilence on the landscape of the radical mastectomy, to which Bernie replied, it's one giant leap for mankind. Remember, the lunar landing was July of '69. So here I found myself in 1973, and I knew that we were waving a red cape in front of the monster. And basically, challenging them to charge, which I can assure you they did. This was mentioned by Vince DeVita and Ed Chu in a publication in Cancer Research. And people said, what are those? Are those magnetic boards in the background? Did you actually get the data in real time? Were you able to know what was going on? We absolutely were. Here is a better resolution of that. We have the treatment arms from B04. Here we have the institutions. San Antonio was institution 17. Here are the patients that were entered from each of the institution, and the red rectangles represent treatment failures. So every day we'd come in and look and see in real time what was going on with these trials. Statistical anathema today, but that was the standard. We shared this with the NCI. We put this into our progress reports even while the trials were accruing. I mean, we'd go to jail today for doing that, of course. So B04 was the Rosetta Stone which started the cascade of trials for the NSABP. B04 was the pivotal trial. Operable breast cancer, clinically node negative, radical mastectomy, total mastectomy, radiotherapy. 1,100 patients, started in 1971. What is a total mastectomy? The lymph nodes are left behind completely untreated. The muscles are left behind untreated. As it turned out, the radical mastectomy group had 40% histologically positive nodes. So here you have a model to determine the consequences of leaving histologically positive nodes behind in 40% of the cohort untreated. And we hypothesized that even though we were leaving behind histologically positive nodes, the outcome would be identical. So here are the 25-year data that we published in the New England Journal in August of '02. We published the original data in 1977, but we knew what the data were as early as 1973 because we had the information in real time. So this convinced surgeons once and for all that nuances on operative themes were not going to enhance survival, and it opened the floodgates to systemic therapy. So we embarked on a Periclean age of clinical trials. Here I am with Bernie in 1975. Data were available in real time without blinding or embargo. Imagine that. No formal data monitoring committees, no pre-specified interim analyses, no penalties for multiple looks at the data and alpha spending. I mean, we thought alpha spending was buying an overpriced Burberry suit at Neiman Marcus. We had no concept of alpha spending, but that was the standard of the day. Results from one trial served as the hypothesis for the next. We had no steering committees and synods to leave their scent on the trials and delay them interminably. And for that brief period of time, we could turn rhetoric into reality. And we're seeing people trying to do that again. Rick Pazder, the commissioner of the FDA, Monica Bertinoli and the NCI, all buying into this. This was our Project Pragmatica in the 70s and 80s when we did nimble sequential trials. This was the rationale for the next study in the retreat from radical mastectomy versus lumpectomy and radiotherapy. We hypothesized, yes, that there'd be a higher incidence of ipsilateral breast tumor recurrence in the non-irradiated group, but that survivorship would be the same. 1,851 patients randomized between 1976 and 84. And these are the 20-year data that we published in October of 2002 and initially published data in 1985 in the New England Journal. And that paper was delayed for a solid year. And we were naive. We did not realize the political implications. There was enormous resistance to publishing this paper, and we paid an enormous price. So here clearly you see no differences between mastectomy and lumpectomy, and radiotherapy. So we immediately asked the question, can we identify a patient subset in whom radiotherapy is unnecessary because survival was not changed? But alas, that would have to wait. And that would have to wait some calamitous events. And because this was imbued with such enormous resistance from the surgical community, and one investigator submitted falsified data, the NSABP was investigated by the most powerful committee in Congress, the Committee of Energy and Commerce. We were shut down completely. We had to submit a plan of corrective action. When all was said and done, 6 out of the 1,851 patients were excluded because of falsified data, which our colleagues from the UK called a tempest in a teapot. Bernie Fisher had to step down as chairman. I became the chairman of the NSABP at that time, and if you ask what was your most endearing contribution to the state of the art, it was rescuing the NSABP during this period of time so that we can go on and fight another battle. A very sad interlude. So the retreat from radical mastectomy, B04, the total, B06, lumpectomy, B32, 5,600 patients showing that a negative sentinel node was equivalent to a negative axillary node dissection, B39, whole breast radiation versus partial breast, and B51, our most recent trial, positive histologic axillary node neoadjuvant therapy. It's converted to a negative histologic axillary node. Do you need regional nodal radiotherapy, or can you eliminate it? This trial is fully accrued, 1,641 patients, a courageous trial, and it was successfully accrued. We should have the results in the not-too-distant future. So, past this prologue, breast preservation, can we now identify a patient subset in whom radiotherapy is unnecessary in the era of genomic algorithms, now that we can identify low-risk patient cohorts? And God knows we tried. We submitted concepts to the NCI over and over. Here is one such concept that I submitted in 2014. Limited by oncotype, good risk, what we thought was good risk, radiotherapy versus no radiotherapy, non-inferiority trial. And here is the critique that we received from the NCI. Granted, this was a period of austerity. The NCI wasn't funding large trials. Perhaps you can help me understand this critique, because to this day, I cannot. It says, Dear Dr. Wolmark, the NCI Breast Cancer Steering Committee reviewed your concept proposal, but did not approve it for further development. Sadly, this is a costly, large-sized non-inferiority trial which will take a decade to complete without clear evidence that the results from the trial will be practice-changing. So they wanted the results of this trial before they would approve it. Does this make sense? I mean, am I misinterpreting this? There simply was no money to do this. And it's to Julia White and the next generation's great credit for being persistent, doggedly committed to this concept, and it's finally become a reality. I have 2 minutes, it seems. So this trial is a reality. It's accruing. It's taken a long time to get there. 270 patients out of 1,670. It's a delta of 4% for IBTR. Again, it's a credit to persistence. This is an important study. So I'm told that I have 2 minutes left. Is somebody going to pull me off the stage? Or Kent is laughing. I think he's fully capable of coming up here and doing it. So one other, let's just look at one area relative to adjuvant therapy and the retreat from radical mastectomy. The first trial that we did was published in 1975. It was the first trial to show a benefit from adjuvant therapy with 2 years of LPAM. We noticed immediately that it was the premenopausal or women under 50 group that benefited. And that being the case, we asked the logical question. We asked the logical question in 1979 and 75, is the chemo benefit a result of ovarian function suppression in premenopausal women? Not only did we ask this as a passing exercise, we did LH, FSH, and estradiol. The results were simply inconclusive. We could not answer the question at the time, and it would have to wait for the development of the Oncotype DX. We were able to develop the Oncotype DX from 14 and 20, and it was remarkable, 19 years. Here's Soon Paik presenting the data December of 2003. Soon Paik, tenfold magnification. Here I am in the audience, very proud of the data. I mean, I think this was at the other end of the bar, not at this lectern. This was a hurrah. And the results were spectacular. Not only was it prognostic, it was predictive. In this 25% cohort, we could eliminate chemotherapy in 75% of the patient population. And the TAILOR-X and RX-Sponder data, 11,700 randomized patients were at unequivocal confirmation of the validity of the Oncotype as done by the NSABP. Yes, because of their large sample size, they were able to do unprespecified subset analysis showing that the premenopausal cohort did benefit both in TAILOR-X and RX-Sponder, and ovarian function suppression was superior in the SOFT trial. So is chemo benefit a result of ovarian function suppression? So this is the OFFSET trial, and it's to Terry Mamonis's great credit for shepherding it through the labyrinthine process of the NCI, premenopausal patients, the groups that benefited in TAILOR-X and in RX-Sponder are randomized to chemotherapy, ovarian function suppression, or ovarian function suppression alone. We've been asking this question since 1975. Alas, it's taken 50 years to bring it to fruition. So the past is prologue. It's taken a good while, but here we are. So, since I won't have time to do this, is this the future? Is this the future of clinical trials? Is this the platform as we're moving to liquid biopsies, where we use ctDNA, and instead of several hundred patients per cohort, we can do this with 60 if we use ctDNA clearance? Is this a transformative change? Or is this a fantasy, a lustful fantasy that will not come to fruition, as so many of our other lustful fantasies have not? You decide. I think it is transformative. I think this is the future for clinical trials. But then again, you have to take this with a grain of benzpyrene. I've been wrong so often, you might not want to go out and bet on this. So how are we going to be viewed in posterity? As the individuals who had the courage, the commitment, the intrepid fortitude to take advantage of the resources that we were given, or is someone going to be inspired to show this slide, an anachronistic historic figure? This is what I have nightmares about. These are my own demons that come to visit me from time to time. And as I reach my best use-by date and I pass the baton to the younger generation, hopefully many of whom are in this audience, I do so with the exhortation, go forth, do better than we, and we will rejoice in your glory. Now, the Brinker organizers allowed me one slide to acknowledge our collaborators. Here it is. It took me longer to make this slide than to put this presentation together. We are interminably grateful to our investigators, both past and present, to the NCI who continuously funded the NSABP and NRG, to pharma. Pharma has been supportive by and large. We don't regard them as the bête noire, but we regard them as partners. And above all, the 120,000 patients who selflessly, courageously participated in the treatment trials of the NSABP. If there are heroes in this story, it is these 120,000 patients. We are grateful for the opportunity to have given this presentation, to receive the Brinker Award, and you have my sincere thanks. And I have overstepped my time, and I'm prepared for the consequences. Thank you so much. The NSABP is here, obviously. Thank you.